Hello, everyone. I'm Anurag Mehta, a cardiology fellow at Emory University in Atlanta, Georgia. I'm a part of the Circulation COVID team, and today I'm joined by Dr. James Fang, the Chief of Cardiovascular Medicine and a Professor of Medicine at the University of Utah in Salt Lake City. Dr. Fang, thank you for taking out the time and being a part of our initiative, Circulation COVID Updates from the Front Lines. We would like to get your perspective on how the University of Utah and the state of Utah have led initiatives to battle COVID-19 and address the healthcare needs of socially vulnerable communities, particularly from a cardiovascular perspective.
Well, happy to be here, and thank you for the invitation to join the Circulation COVID team. Probably I should start off by telling you a little bit about Utah, for those of you in Atlanta and other locations that may know little about our state and our surrounding region. So the state of Utah is about 3 million people, and most of it's concentrated in the greater Salt Lake area. As an academic healthcare system, we serve 5 states, 10% of the landmass of the United States, and we are the only academic medical center for several states here in what we call the Intermountain West. And to get to your specific questions, we started our planning about a month ago when we started to hear about the surges going across the country. And I would just like to preface my remarks by saying that I think we have done a great job here, and really a shout out to my colleagues, the healthcare system, and the leadership of the University of Utah that has got us prepared so quickly. So in full disclosure, we have not surged yet. To give you some data, we are in the top 5 states of the country in terms of testing. So we've tested about 35,000 people. So it's one of the highest per capita rates of testing. We have about 1,700 cases, and we have a very low case fatality. We have, I think this morning, 13 deaths in the entire state due to COVID. And in terms of testing, 1 month ago when we decided to do this, our hospital and system was very full. As like all hospitals, we were running at a 95% capacity for inpatient and ICU beds. And with our planning, we've been able to accommodate now a potential COVID surge, or I should say not potential, the COVID surge whenever it comes. So we are now down to about 40% capacity in our acute care areas and 65% in our ICUs, all in preparation to accommodate the surge for not only the greater Salt Lake area, but as you had asked me, rural America. Now, of course, we're cardiologists, and there's been a lot written and a lot reported about the impact of COVID on the cardiovascular system. And in fact, I think yesterday, Harlan Krumholtz from Yale wrote a little bit about what we're all seeing in a variety of locations with respect to heart disease. So we have, like everybody else, seen a decline in our urgent cardiovascular care. We still see our STEMIs, we still see our non-STEMIs and unstable angina, and we still see patients with heart failure, but the volume of patients with these unstable coronary syndromes seems to have attenuated. Now, why that is, hard to know. A lot of speculation, a lot of hypotheses, but nobody really has a clear idea. But one of the things that we're concerned about as cardiologists, as you know, particularly with rural America, is people already have difficult access to care. And with this COVID crisis, we are worried that there's a reluctance of rural America to even access us because of the concern of COVID. And, this has already affected our ability to go see them because, of course, we're trying to transition all of our visits to what we call virtual visits. So, for example, our cardiovascular enterprise here in Utah, we get on airplanes when we do our outreach clinic. We don't drive an hour to a suburb of Atlanta. We go to communities like Billings, Montana for 2 days. We get on a commercial flight and fly there to see patients. But we've transitioned all of those visits, frankly, to virtual visits. And we're hopeful that the transition to virtual visits for our rural community will be something that we will, frankly, become a part of our new normal in the post-COVID era. I can tell you that the patients really appreciate it. Rural America, driving 3 hours to see me for a 20-minute visit is just not a great patient experience. But when we can do this and look at them in their own home, and they can go to the bathroom and bring the pill bottles to the screen and I can look at them, I can tell you it's a real advantage. And it'll be fascinating to see how much of this we can keep going in the post-COVID state. So those are just some preliminary comments.
That sounds wonderful, Dr. Fang. Thank you so much for the insightful comments. We are also interested, based on what you were mentioning in terms of the University of Utah providing care to patients in 5 states. One thing which we would like to learn about, in addition to what you're already doing, is alternative models of care, such as the hub and spoke model, which can be shared with satellite or rural partners, and how patients will be referred or transferred to the University of Utah Medical Center in case of medical emergencies and cardiovascular emergencies.
Those are a few concepts to think about. Maybe I'll just start with the last, which is, are we taking on patients with acute cardiovascular illness or subacute? And the short answer is yes. But of course, the cardiovascular service line and cardiovascular services are really part of a larger fabric. And so we have to coordinate this with the system at large. What do I mean by this? I mean that if somebody calls with a patient in shock, we take the call, and the call is routed through our transfer center. And if we believe we can help the patient, we will, but it's also reviewed by hospital leadership to say, do we have the ICU capacity right now to accommodate this patient in shock, yet handle a COVID surge? And, right now we are pre-surge. And as I described, our bed capacity does allow us right now to take those patients. Now, should we surge, there will have to be difficult discussions about our ability to take patients in that situation. And we're trying to do this in a nuanced case-by-case review, because it's really hard to put a policy forward. Fundamentally, we are here to help patients in the region. And heart disease continues despite the COVID illness, as do other respiratory illnesses go on. And so we have to make sure that our doors are open to accommodate those patients. So we're doing that. With respect to the hub and spoke, and so we actually just published this month in JACC, heart failure, our experience with shared care, because we are a major referral center for advanced heart failure, transplant and VAD specifically. And, we have a very mature effort in the community with shared care. So, when patients with VAD or transplant are several states away, coming here for their appointments is just not really practical. And, a lot of our referring physicians are colleagues and very comfortable in taking care of many of the things that in an urban setting might be considered the more standard of care. So, we've really worked hard at that. But, what we've done really is transition even all those visits as much as we can to a virtual platform.
That sounds great, Dr. Fang. Thanks again for your time, and we really appreciate your leadership and all that you're doing at this time for making a difference in the care of our patients.